Sir, you are on live. Please start your session.
Okay. Sir, shall we start?
Yes.
Good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. This webinar is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993, and we have got 30 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries, 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Heathrow Healthcare is Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which they received an award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar, Role of Oseltamivir in Flu Management, we have got Dr. Pramod Jog as moderator and Dr. Sanjay Nathu and Dr. Sainath Pawar as speaker. Welcome Dr. Jog, welcome Dr. Nathu, and welcome Sainath Pawar. Dr. Pramod Jog, sir, we know is Professor of Pediatrics, G.Y. Patil Medical College, Pune. Sir is President of IIP 2016, Steering Committee Member GAVI, CSO 2016 to 19, Chairman Mini Recipe Module IIP, author of book Cophology. Welcome, Dr. Jog. Dr. Sanjay Nathu, sir, is MD DNB Pediatrics, MN AMS FACEE. Present currently, Professor and Head of the Department Pediatrics from March 22 till date is Srimati Kashibai Navale Medical College and General Hospital, Pune. Consultant pediatrician in Shashwat Hospital, Kothur, Pune, and Dr. Nathu's area of interest include pediatric pulmonology, pediatric infectious disease, pediatric emergency medicine. Dr. Nathu has been President IIP Pune Branch 2021, member of Pediatric COVID Task Force Pune Division, organizing team member of numerous national and state pediatric conference training, member of National Academy of Medical Science India, fellow of Academic College of Emergency Experts, Pediatric Emergency Medicine, and has been member of Indian Academy of Pediatrics, Indian Medical Association. Welcome, Dr. Nathu. Dr. Sainath Pawar, sir, is MBBS, MD, DCH, and FCPS. Sir is fellow in Allergy and Asthma from University Hospital of Leicester, UK. Certified Pediatric Flexible Bronchoscopist by APPS and IIP, consulting pediatrician and pediatric pulmonologist, consulting allergy and asthma specialist, President Kolhapur Academy of Pediatrics 2024, National Trainer for NTEP IIP Action Plan, National Trainer for Pulmostar IIP Module, National Trainer for IIP RIP Module, and Executive Board Member for Maharashtra Respiratory Chapter of IIP. Welcome, Dr. Sainath Pawar. With this brief introduction, I hand out the session to Dr. Pramod Jog. Over to you, sir.
Thank you, Dr. Prashant. Those kind words. And let me share my screen so that we can start with the discussion of today's topic related to influenza. Just give me one moment. So the topic for discussion today is use of Oseltamivir in flu management. And we are going to discuss this topic with two influencers, Dr. Sanjay Nathu from Pune and Dr. Sainath Pawar from Kolhapur. I would say, now that we are going to discuss Oseltamivir, they are the two Veers, okay? Veers are, very intelligent and respected pediatricians, okay? So that is VIR for me today. And of course, I have been the presidential strain of IIP in 2016. IIP has different strains of people coming every year in the executive board and in the office bearers zone. So I was there in 2016. And if you can see, every influenza virus has its own nomenclature. So I have tried to put my name in that fashion, wherein, the place of origin, the month and the year of origin, and the name of the area are usually depicted. So remember that influenza is not to be taken casually. Many parents, they say, क्या influenza तो है उसमें डरने की क्या बात है, but it is not so. Influenza is not to be taken lightly because it doesn't only create mild illness, but it produces severe illness also. And everyone is aware not that the monsoon is in full swing. Only few people are happy, like the farmers, the frogs in the farms, the doctors because of the number of patients, and the pharma because of the sale of the medicines. But whenever someone says it's viral, it's something which is rather sometimes very terrifying, because we have seen COVID-19 taking a different turn after a few days, 6, 7, 8 days, and going into a storm. So that's a cytokine storm. Okay. And we have also seen influenza patients, going into serious forms like ARDS. And in general, I'm sure all our listeners would agree that the incidence of respiratory infections and the otitis media and the adenoidal hypertrophy and influenza and adenoviruses and so many viruses basically during this particular season, not only during this season, but over last 2 or 3 years, these patients have definitely increased in the OPD. Dr. Nathu, do you think there is any particular reason for the rise in the viral infections over last few years?
Good evening, everyone. Good evening, Jog sir. Yeah, so a very important question, and I'm sure all of the pediatricians who are attending will agree that they have been seeing a lot of viral infections since last several years, maybe 4, 5, 6 years. The number of bacterial infections are definitely less as it was there before, say the pre-COVID era, for example. And the use of antibiotics is also not commonly required. We are getting most of the cases which are of viral infections. The probable reasons, if you think about it, could be the better coverage of vaccines, which are taking care of many common bacteria, for example, the pneumococcal vaccine, the H influenza, and so on. So the number of patients coming to our OPD with bacterial infections have gone down definitely, and the viral infections are definitely on the rise.
Right, you're right. And many times, we get a picture like a viral illness to begin with, but those viruses like adenovirus have become now bad adenoviruses because, they come with high WBC count, high CRP, and we are many times, deceived by this virus because the presentation many times, is like a lobar consolidation. We feel that it's bacterial, but in fact, it's adenovirus. So different things are there. We will try to discuss most of these. And after COVID, we started witnessing waves of different viruses. Okay. But in general, in medical field, there is something called as a prion effect. And whenever there is some big pandemic, say for example, COVID-19 was a pandemic, after that, the flu incidence started increasing greatly. Okay. And it's type B that has been found to come up after some other epidemic or pandemic. And this type B, though apparently we do not know much about it, for unknown reasons, it is seen at a higher concentration in the eastern part of our country. And the Victoria and the Yamagata strains are the ones which are not very simple, and they can create serious problems. So after COVID, we have seen those different waves of viruses like the hand, foot, mouth disease, the respiratory syncytial virus, the adenovirus, and even older children are getting affected by these. And I remember these measles also had, come up in different parts of our country where the immunization coverage was on the lower side. So when a 3-year-old boy came with fever, cough, cold, and progressive breathlessness, and was having tachypnea with a saturation of 85% in the room air, and the X-ray picture suggesting acute respiratory distress syndrome. He was admitted to the PICU, was ventilated, received oseltamivir, and the throat swab showed H3N2 positivity. He was ventilated for 3 days, and then he was all right. Apparently, everything appears to be in sequence, but oseltamivir always could have been started little early, particularly in the season of influenza. Influenza is known to be more in monsoon, though it's a year-round infection. In monsoon, it's in the peak in most of the parts of our country. And that's why in a previously healthy child coming with cough, cold, and fever, progressing over 3 days, and coming to us in a bad shape, it is important that the treating physician knows that oseltamivir is an important antiviral which can be used in flu season in particular categories of influenza to avoid complications. And that's why there are some confusing points as they are related to flu. I put them as conclusion. And what is this conclusion? When a child comes with respiratory infection, one should try to find out whether it is bacterial or viral. We all know that bacterial infections are localized. So the child may get follicular tonsillitis with cervical tender adenopathy or may get only pneumonia. Usually bacterial infections, they are localized. Okay. While viral infections, we know they are generalized. The child will have cough, cold, fever, red eye, rash, at the same time might have diarrhea. So more than one system is involved. So if it's viral, what is the virus? Whether it is rhinovirus or respiratory syncytial virus or adenovirus, influenza virus, parainfluenza virus. And if it is influenza, whether this is H1N1 or H3N2 or type B, and whether one should start oseltamivir upfront. So it is important that in monsoon we are aware of influenza-like illnesses. And remember, flu is the father of all influenza-like illnesses. A child comes with headache and muscle pain and tremendous weakness, and father many times has to lift up and a child who is around even 8 or 10 years because of weakness. The child finds it very difficult to come and walk on his own. And if you have a look at the influenza in India, the incidence of influenza and related deaths increases, alarmingly in India from 2015, 2019. And just today, in one of the reputed American journals, there has been a report of influenza season of 24-25, where maximum number of deaths in US have occurred during this particular year after COVID-19. There were almost somewhere around 280 deaths, of which majority of them were because of H1N1. And surprisingly, almost 80% of those who died had not received influenza vaccine, which is something, surprising in a country like US. And of course, we should know a bit about the KYC of this naughty influenza virus. I call it naughty because it's an RNA virus, and all those RNA viruses, they change their, genetic makeup very frequently. So COVID, influenza, RSV, all these RNA viruses are to be, looked at with a lot of caution. So influenza A is the one which causes frequent epidemics. And as it is seen in human beings as well as in animals, there are periodic pandemics because all those viruses from the birds, from the human beings, they usually, go to the pig, and the pig acts as a mixing vessel where a totally new virus comes in the circulation, like the one which came in 2009. Influenza B, on the other hand, infects only humans, and it doesn't show any antigenic drift. Okay, that's why the influenza B viruses in the vaccine like Victoria and Yamagata remain the same, while the H1N1, H3N2, they keep changing. And remember that this virus has two important glycoproteins on the outer side. HA is the molecular key because that hemagglutinin is the one with which the virus attaches itself to the respiratory epithelial cell, and the virus is able to release the RNAs into the respiratory epithelial cell. The virus multiplies, and the virions which are produced inside the respiratory epithelial cells, they are about to exit out of that respiratory epithelial cell, and they need someone to separate them. So this neuraminidase of influenza virus usually acts as a molecular scissors. So these viruses get separated, they get out of the respiratory epithelial cell and infect other respiratory epithelial cells. So if this exit of these virions is blocked by some mechanism or the other, like for example neuraminidase inhibitors like oseltamivir, then the spread of the viral infection to other respiratory cells and complications like pneumonia and ARDS can be prevented. So one must know some of these basic facts about the influenza virus, and there have been four major global pandemics. One of them was in 1918 to 1920, and actually it was a misnomer to call it a Spanish flu because it was seen in New York and so many parts of US like Los Angeles and others. And quite a few, in millions, people were affected by influenza, and quite a few died. In fact, it is said that almost 1/3 of the world's population was infected with influenza in that period. It was again H1N1. At that time, there was no treatment available. So the only treatment available was bed rest, fresh air, fluids, and nursing care. And oseltamivir obviously was not there. So the mortality at that time was quite high. Then there was 1957, 1968, and 2009, four major pandemics in the world. Dr. Sainath, just wanted to know whether you have an idea about any update in the epidemiology and the circulating strains of influenza viruses affecting pediatric population in India, and maybe in case if you have investigated a few cases in your area of Kolhapur, then we would like to know that. Yeah.
Yes, sir. So basically, generally we are doing influenza tests only if the patients are reporting. Other patients we are treating empirically only. But those we have done few of the influenza tests, and this year it was morely seen H3N2 virus. Previously, though few years back it was H1N1 virus, but nowadays it is more of H3N2 virus. Is more prominent nowadays. So we are seeing this H3N2 virus is more prominent nowadays, and sometimes in last RSV and adenovirus was also there, but more of if we say about influenza, it is mainly the virus is H3N2 virus.
Okay. And Dr. Nathu, do you have any experience on this?
Yeah, so we are lucky to have the National Institute of Virology in Pune, where we do send our nasopharyngeal swabs and we do get the reports regularly. So as Dr. Sainath mentioned, H3N2 has been the predominant strain this year in cases of influenza. We are getting H1N1, but their proportion is quite less. And we are also getting occasional cases of influenza type B, which are also there, especially in the older children mainly. But the predominant strain has been H3N2 in this season.
Okay, that's great to know. And maybe it's quite apt that the WHO has now ordered for a trivalent influenza vaccine, which would probably not contain one of the B lineages, and that's why WHO, the data which WHO gets, shows that the one of the strains of B is not seen over last few years, and that's why the quadrivalent vaccine is now likely to be changed to the trivalent vaccine. Of course, this particular issue is under some debate and some discussion, but in general, some of these strains are not seen, and that's why some of them are not being added to the newer vaccines. So, as you all rightly said, the surveillance of early 2025 indicates that S3N2 is the predominant circulating strain in India. And this flu virus, as all of us know, it spreads to others, and the transmissibility of this virus is great. And within 48 hours, the persons in the family, they get infected. So whenever you get more than one system in a child involved, I already told you that it's viral. When there is more than one member in the family involved, again it's viral. And when there are more than one families in the community, then that's viral. And the viruses are spread mainly through cough and cold and sneezing. And these droplets, they land in the mouth or the nose of the people who are nearby, or onto the surfaces like the table or the handkerchief or the hands of the person. And this spread by fomites is also known in case of influenza. Dr. Poir, what different clinical scenarios you have seen with influenza in the pediatric population?
So ge- generally the patient will come with generally acute onset. It will be acute onset. They will prominently come with fever. Initially, it will be high grade fever. There will be cough, sore throat. There will be some running nose. There will be weakness. There will be myalgia, headache. And generally, as I'm going to discuss in our cases, that we are saying that this generally influenza virus, they are coming with the generalized weakness, and patients are becoming drowsy, or they are becoming sleepy over next, especially after 3 to 4 days of illness. This is the observation which is seen during this epidemic, we can say. And there are sometimes they can come with atypical features also, like if they are got high grade fever, they may come with febrile seizures. Sometimes, rarely, we have seen the patient like encephalitis, encephalopathies, or sometimes they may come with gastrointestinal symptoms also. But majority is a fever, cough, cold. This is a prominent presentation seen.
Very good. And Dr. Nathu, you have any additional observations?
No, so most of the patients are having the typical symptoms of fever, cough with body ache and myalgia. Occasional atypical presentations are seen, and many times the fever is tending to be a little prolonged. And because of that, we tend to investigate on say third, fourth day, and commonly we are finding a picture of leukopenia and sometimes even thrombocytopenia as well. So this is something which we have observed this year in many of our patients.
Okay. And as I said earlier, these children, they basically have severe headache, body ache, muscle pain, because influenza is a systemic illness. As you can see, rhinoviruses and others, usually they remain localized, but influenza is a systemic illness, and that's why it creates all those problems. And being viral, it can also produce other system involvement like GI symptoms like vomiting and diarrhea. And as Dr. Nathu said, we have seen patients coming with high fever and febrile seizures. And some of our colleagues have also seen encephalopathy and myocarditis. And that's why it is very important that you know a bit more about this particular virus. Though one should be aware that the influenza-like illnesses, H1N1, that is our influenza, whether it is H1N1 or H3N2, severe acute respiratory infection, and illnesses like COVID-19, almost all of them, which are the respiratory viral infections, they have many of these symptoms in common with a bit of variation in some of the presenting features. And when it comes to the emergency warning signs of flu, Dr. Nathu, will you like to elaborate a bit as to what all the practicing pediatrician or the parents should be aware, as to when a child comes with influenza, what are the various things that could be called as red flags or emergency warning signs of flu?
Yes, and this is very important because many of our flu patients are going to be coming to us with simple symptoms, and unless we make the parents aware and unless we ourselves are aware of the warning signs or red flags, then it can spell trouble. So in children, fast breathing with increased excursions of breathing, cyanosis, and poor intake, especially if there's associated vomiting as well, then a poor intake would not be a very good sign to have. A child, as Dr. Sainath was mentioning, tending to be a little lethargic, not wanting to wake up, having a severe malaise and not interacting is not good. Also, at the other extreme, that a very irritable child is also something which we should be aware of. And rashes do come on and off with this influenza as well, but they would not be that much as a part of a red flag in my book. In adults, again, difficulty in breathing, shortness of breath, discomfort in the chest or abdomen, or dizziness, some mental confusion, decreased alertness, persistent vomiting. All of these are definitely going to be something we should be aware of. And deciding when to admit the child, then I would definitely think of children who are not able to eat, not able to retain anything, have some trouble breathing, or are becoming dehydrated. They would definitely preferably be managed in the IPD setting.
Sure. Very good. This is important because influenza is an illness basically of children, okay, and it spreads from children to the adults. So it is important that we know both the presentations in children as well as in adults, because as during COVID we saw that basically the illness affected adults and then it spread to the children, and that's why vaccination and other efforts were more concentrated on adults, and later on they came to the adolescents and children. But in case of flu, the vaccination starts right from childhood, right from the completion of 6 months in a child. And it is important that those contacts in the house, there are many times, people who are diabetic or asthmatic or those who are on steroid therapy, they can catch infection from children. And in case if they develop some of these symptoms, then it is important and prudent that, they are also taken to the casualty or to the medical facility for evaluation. And one should be aware that flu, as I said in the beginning, is not a simple virus. It can complicate into certain things which can begin with the alphabet A. So it could be a complication into ARI, acute respiratory infection in the form of pneumonia or acute respiratory distress syndrome, acute otitis media, absenteeism from the school and from the offices, which impacts the amdani, that is the income of the parents, and also the antibiotic abuse. It is important to know that some of these viruses basically they set the stage in the respiratory epithelial cells wherein the other bacteria invade. And that's why 25% patients of influenza, they get infected with either Streptococcus pneumoniae or Staphylococcus aureus. And that's why it is many times, difficult, to differentiate whether it is purely viral or a combination of bacterial and viral infection. It is very important to know that along with flu vaccine, we also give pneumococcal vaccine, so that the deaths related to the pneumonia, which has complicated influenza, they are also prevented. And that's why, particularly in a in an age group above 50, also it is necessary that we give flu vaccine annually, as well as pneumococcal conjugate vaccine to adults above 50. And now let us come to the treatment of influenza. And before we discuss the categories of influenza and the management category wise, I will just tell you something about this molecule oseltamivir, which is a neuraminidase inhibitor and which blocks the release of virions from the infected host cell. And this particular molecule is active against influenza A as well as influenza B. There is another group called adamantane, which is active only against influenza A. And oseltamivir basically is a potent and a selective inhibitor of the neuraminidase enzyme. And it's a prodrug which is converted into the active form oseltamivir carboxylate, and it inhibits influenza virus replication and the further progression, and it prevents the spread of infection. This is only a diagrammatic representation wherein we can see that virion, which is releasing new virions and leading to continued viral replication. This release is blocked by the neuraminidase inhibitors like oseltamivir. And this was the first oral neuraminidase inhibitor which has been approved in more than 100 countries, and it has been approved by CDC as well as American Academy of Pediatrics. And then, Dr. Sainath, will you just like to elaborate a bit about some categories of treatment and the current recommendations for the use of oseltamivir on the OPD and the IPD basis?
Yes, sir. So basically, generally for treatment of influenza, there are three categories like category A, B, and C. First category is very uncomplicated and mild categories. It is in which patients are having only fever, cough, cold, plus throat pain, with or without body ache, headache, diarrhea, vomiting. It may or may not be there. So this is our first category, which most of the patients we see in OPD are in this category. So that is called as category A. Then category B is like high risk and with severe or severe symptom. So which includes the patient with high grade fever, severe sore throat in addition to category A symptom, and who may need a home isolation and oseltamivir treatment for the here at a stat. It also include the individual with category A symptoms and pre-existing high risk condition like children less than 5 years, especially more focus on the less than 2 years, or the pregnant woman, or the patient if the elderly patient above 65 age. Then some patient may having chronic health diseases like lung diseases, heart diseases, kidney diseases, blood diseases, diabetes, neurological disorder, cancer, HIV. All these patients comes into this means who are at high risk with this symptom. They come into category B, and then comes category C, that is severe disease. So this category includes the patient with category A plus B symptom, A and B symptoms, and also they show the severity signs which is showing that it is a severe disease like breathlessness, chest pain, drowsiness, low BP, bloody sputum, child is drowsy, they have got persistent fever, they have got fast breathing, difficulty breathing. All these things comes into category C. So category E is uncomplicated, mild. Category B is high risk or with a moderate symptom, we can say, and very critical patient comes into category C.
Right, right. Very good. And then I'm sure
And
everyone
if
is.
you go on treatment, like category will A will have only symptomatic treatment like home isolation, bed rest, plenty of fluid, paracetamol for fever, all those things. Category B above treatment, it will generally we will prefer to give antiviral like oseltamivir and preferably within 48 hours of onset of symptoms. And category C will require immediate testing also, and it will require hospital admission. It may require ICU admission and oseltamivir treatment also.
Right. Dr. Nathu, would you like to add anything to what Dr. Pawar has already stated?
Just a word about the testing part. So the category A definitely need not be tested and just be treated in a symptomatic basis. Category P patients, preferably as Dr. Sainath said, we should start oseltamivir, but testing may not be required before starting oseltamivir in such situations. Whereas category C, you have to start oseltamivir, but also preferably do the testing as well. So that is something which we need to remember, that category B patients, no testing is required before you start oseltamivir. You can upfront start oseltamivir in this group of patients.
Right. So this is the chart which gives you details about the dosage and the recommendations of oseltamivir. And in general, for therapy, the medication is given twice daily, while for chemoprophylaxis, it is given in a once daily dose. And in adults, the dose is 75 milligrams twice daily for therapy and 75 milligrams once daily for 10 days for chemoprophylaxis. And in children, depending on the weight bands, the dose ranges from 60 milligrams per day to 150 milligrams per day. And in infants, the dose is 3 mg per kg twice daily. And now the question is, Dr. Nathu, how does early initiation of oseltamivir influence the clinical outcome in a case of influenza, and whether we can administer oseltamivir even if, when the patient comes a little late, maybe on day 4 or 5 of illness? So what is your opinion?
So in a given situation, I would prefer to start oseltamivir as early as possible, because there have been several studies which have showed that the results after treatment with oseltamivir are best if the medicine is started early, that is before 48 hours of onset of symptoms. This will help in early recovery, especially in high-risk cases, and also prevent the chances of them progressing to complicated situations like a pneumonia or encephalitis and so on. In short, we would be able to avoid hospitalizations in the majority of the children. So starting early definitely has benefits in preventing complications as well as preventing hospitalization and early recovery. Having said that, sometimes we do get patients who have been moving around from doctor to doctor and reach us by about fourth or fifth day with maybe some complication or persistent fever. And though oseltamivir is to be started early, ideally, that doesn't mean that we should not start it later. So even on day 4 or day 5, if we encounter a patient who we highly suspect to be influenza, then it is worthwhile starting oseltamivir even on day 4 or day 5 or day 6, because we in practice have been seeing good results even when we start oseltamivir late.
Right, right. And of course, in Pune, there have been some institutes where research was done on those patients coming late and receiving oseltamivir, wherein it was found that the mortality was also substantially, less in those patients, even with oseltamivir being started little late. So there have been quite a few clinical trials related to oseltamivir and its impact on the, antibiotic usage, influenza-related low respiratory complications, and hospitalization, and also in adults with pneumonias, a lot of advantages. And that's why, Dr. Powar, there is an important question which our clinicians many times, face, whether, I should start oseltamivir empirically. That means just, the patient comes with fever, cold, cough, appears a bit severe, and I start oseltamivir, or whether I should wait for the investigations like the throat swab report. What is your opinion?
As we had discussed that as we had discussed that category wise, even if you see that generally category A will not require any treatment, and if the category B patient is there and the patient has got classical symptoms like fever, cough, cold, myalgia, and all those things, and you are strongly suspecting it is an influenza virus, and sometimes see in our area also some patients are not affording; they do not want to spend. So in that case also, we will start oseltamivir upfrontly because we are strongly suspecting influenza. But as we discussed, if the patient is very critical, then it is important to document that what it is. So then in that case, we should go ahead with the test also, and then but we should not wait for the result to start oseltamivir. You send the test, and if the patient is critical, we can start on the oseltamivir, and depending on the test, we can decide how to go ahead further. So these are the things. So if in patients are affording, we can prefer to do the test also, and if the patients are not affording, then we can go without test also. We can start oseltamivir.
Right. Very good. So there are recommendations, and even WHO recommends that empiric treatment is good. Treatment should be started as soon as possible, and the laboratory confirmation is not necessary for the initiation of therapy. However, if the lab test, comes negative, it does not mean that this particular child doesn't have influenza, and that's why it is better to give oseltamivir. And if the test comes positive, it is known that it is in majority of the times H1N1. However, if the test comes negative, many times there are some fallacies in collection of the sample, wherein the virus has not been caught, and that's why the test comes negative. We will discuss this issue little later in relation to some of these cases, and that's why it is necessary that our colleagues know that in an influenza season, in a child with category B and C, one should not be afraid of starting oseltamivir upfront. It is very important because the effectiveness of this medication is in the first 48 hours. When you start it early, it acts the best. Okay. And that's why early empiric therapy, supportive therapy, and monitoring is very important in these children with influenza. Okay. Now we'll be seeing certain cases, and I will stop sharing for a while, and I will request Dr. Sainath to share some of his experiences related to the cases of influenza, and then we will take up some questions.
My screen is visible, sir?
Yes, it's very good.
Yes. Yeah. So I am going to discuss two cases. One is our IPD case and second is our OPD case. So as we are seeing many patients with viral infections, so these are the cases that we see in our daily day-to-day OPD. So this is a 3 years old female child. She was admitted with cough since 5 days, which was dry type of cough, cold since 6 days, fever since 5 days, high grade intermittent fever. On examination, child's heart rate was 125, respiratory rate was 35. There was tachypnea. There was on respiratory examination, there was bilateral occasional clefts and bronchi. So our provisional diagnosis in this patient was lower respiratory tract infection, and we admitted the patient. We had done a CBC as the patient was tachypnic. Definitely, she was needs observation, so we admitted the patient. Investigation was done, like CBC has shown HB of 11, WBC count of 3,500 with polymorphs 26, lymphocyte 72%, eosinophil 2%, monocyte 2%, and with a platelet count of 1,66,000, and CRP was, we can say, normal, it was 4. So here there was a picture of leukopenia, the child with lymphocytosis, and platelet was on the lower side, and CRP was the normal. So here our thinking goes in favor of viral illness because the season is also of viral illness. This was the X-ray which has showing some haziness seen over right mid zone and lower zone, and there is here some haziness in the left upper zone also. So this was the X-ray and this was the clinical picture with reports. So in view of like it was a LRTI, we were suspecting a actually viral infection, but still started on IV antibiotic. He was started on bronchodilator nebulization. Oxygen was started, but the child was not maintaining the saturation on oxygen. So the child required the high flow oxygen. And then on high flow, the child was maintaining saturation. Slowly, what happened on day two, tachypnea was reduced after all these supports, nebulization and everything. But on day three of this admission, child was become drowsy. As we had discussed, that drowsy child, lethargic child, child was not sleeping, more of sleeping only. Child was looking sick, and child was not accepting feeds. So immediately in this patient, as the child was turning serious, so we had immediately sent the H1N1 swab, which came positive later. Immediately we started this patient on dose Altamir after sending the start. And next 48 hours, patient has improved. Patient, we could reduce his high flow. We came on oxygen and then slowly oxygen was also removed. So this was the patient who has responded very well with oseltamivir. Though it was a IPD patient, though he was requiring ICU, uh, and the patient improved very fast. So that was our first case. Second case was 1-year-old child, he was Raghav, his complaints of cold since 4 days, coughs dry type since last 2 days, fever since 2 days. This is a routine OPD scenario that we are seeing daily. No other complaint. Child was well, feeding well, child was playful. Treatment was, we had done a symptomatic treatment. We are given him paracetamol and that's all, and anti-cold. Yeah. So the patient went home and we had asked him to follow up after next 2 days to see whether any red flags are coming. So patient came after 2 days, fever reduced, cough cold was there, but again child was having decreased activity. The uh, mother was telling that the child is only sleeping and not getting if even if she wakes up the child gets up for 5 to 10 minutes and again goes going to sleep, and the child was not playful. So this was again a red flag, and red flag was us. So we had done a CBC, WBC, sorry, HB of 9.2, total count of 4,500, platelet was normal 2,80,000. Again, lymphocytic predominance. Dengue was done because low platelets, WBC count was low, and which was negative. Patient was not very affordable, so we have not sent the H1 influenza test, and the Oseltamivir started on OPD basis only. And within next 24 to 48 hours, we asked the patient that he child may require admission if the child's condition does not improve, but slowly after 24 hours, child showed improvement, activity improved, patient was better, and then he did not require IPD also. So this was a OPD case, which was we see routine in our routine OPD patients. So these are our two cases that I have come through in last this few days, actually, we can say. So I would like to hand over to sirs
Yeah, sure,
for
sure. Yeah,
his
that's
inputs.
great. Yeah, it's very great. And then I must say that one of these cases, wherein you have investigated in details, it is important that in the months of monsoon, we have all those viruses, not only the respiratory viruses, but even viruses like dengue also can infect children. And some of the presentations related to the laboratory investigations, like the WBC count going down, the platelet count going down, they are many times seen. So, Dr. Nathu, what is your observation about the laboratory findings in case of influenza and sometimes those co-infections with viruses like dengue? Do you have rather have you come across cases like these during this season?
So as I mentioned, we are getting a lot of patients with thrombocytopenia and mainly leukopenia, and fever is also tending to be a little prolonged. So we do end up thinking in terms of dengue. Though I have come across hardly any cases with co-infection of dengue with influenza. We need to do and rule out dengue in such situations, but both existing together, I have not come across. Cases with influenza and RSV, yes, we have seen a couple of cases with where the nasopharyngeal swab has isolated both influenza as well as RSV. And as many of us may be aware, along with influenza, RSV is also has been circulating in the community for the last couple of months, where we're getting a lot of patients with RSV type bronchiolitis type picture in the first couple of years.
Okay. So, Dr. Pawar, you have any additional information to be shared?
So actually, what is happening to means we have seen few patients who are coming with reports only directly, and they are coming with low WBC count, low platelets, and they are assuming that it is dengue. So we have find out the new terminology like dengue like flu. So we are telling them that it is dengue like flu because they are coming like a patient has got dengue only, as because they know though that if platelets are low, it is dengue only, and patient is sleeping. So they are coming like a patient has got dengue only. Aisa. So we are doing the dengue report. It is coming negative and it is sort of influenza virus.
Yeah, I understand what you want to convey. So it is better that in a child wherein pediatrician is suspecting influenza or has influenza proved by the laboratory reports, one has his antenna alerted towards dengue also, because both these illnesses are biphasic illnesses, and on 5 or 6, if at all a child suddenly worsens, then one should not be caught unaware. And then Dr. Nathu, after looking at these cases which Dr. Pawar has presented, one question comes to my mind about the rationality of antimicrobial therapy. Sometimes the presentation is so much like influenza that you put the child on oseltamivir in view of the lab reports or the categorization, and then the child somehow continues to be toxic, and you tend to start with some antibiotic like amoxicillin. On the other hand, sometimes the child comes in a very bad shape and is toxic and the counts are very high. You tend to start with some antibiotic like amoxicillin, but even then, the child doesn't improve, or sometimes the swab report comes positive little later, and then you want to start oseltamivir. So in both these situations, how would you rather try to balance the management?
So, depending upon how the patient has presented, for example, if the patient has presented with a typical mild or uncomplicated picture of cough, cold, fever, myalgia, I would definitely not think of starting antibiotics in the first 2, 3, 4 days at least. Most of these patients we all know are going to be viral, which may or may not require oseltamivir depending upon the situation. But I would not be very keen on starting antibiotics in such a situation. So one needs to be aware about the epidemiological process going on in the community. For example, in the recent months, we have had a lot of influenza cases. So any patient, though coming with very high fever and looking a little ill, more likely is going to be influenza rather than bacterial infection. Having said that, patients, as you rightly said, who come in a severe condition, for example, they are requiring inpatient management, they would be those in which I would definitely consider adding an antibiotic along with oseltamivir, of course, because in such situations, one of the possibility may be an infection with a streptococcus pneumonia or something of that sort. And in these children, starting oseltamivir with antibiotics would be justified.
Okay, I think that's an important point which our colleagues also should take home and take the decision rationally. Now, Dr. Pawar, I just wanted to ask you as to what is your experience about the throat swabs, and how many people, those whom you advise throat swab, they really go and get it done, and how many patients you have to start oseltamivir upfront because, as you said earlier, that they may not be able to afford. And what is your experience in general about these throat swabs?
So generally, as I said, ki most of the time we are not, because we are most of the time we are seeing type B patients only. Very rarely we are seeing, or generally in OPD patients, or we critical centers will see a type C type of patient, but generally in OPD we are seeing type B of patient. So generally we are not uh, forcing them to do influenza. If the patient is very educated, they wants to know what it is, then we will advise them the throat swab. And but if we are suspecting, yeah, we'll start oseltamivir and then we'll wait for the throat swab. So as I said, few of them has come N3, H3N2 positive. So that is the thing. But most of the patient we will be starting oseltamivir upfrontly without test only.
Okay. Okay, that's great. And then Dr. Nathu wanted to ask you something about oseltamivir as to how well is it tolerated? Do children vomit often? Whether there are any major adverse effects of oseltamivir that you have seen? So, what is your experience?
So oseltamivir, as we all know, comes only as an oral preparation, either capsules or a syrup. So over the years, we have found out that oseltamivir is quite well tolerated. Hardly any problems with the children taking oseltamivir. The only precaution which I advise most of my patients is that they should not be taking it on an empty stomach. They should have something orally, and after that take oseltamivir, because the only thing which we have seen sometimes is oseltamivir causes a little bit of gastritis, which may lead to vomiting. Otherwise, the palatability and everything is quite good, and the children are quite comfortable taking this medicine.
Okay, very good. And have you seen any particular complication related to influenza? Like, as we were discussing about encephalopathy. So, have you really come across these complications in the practice?
So, not couple of, several patients with febrile seizures we have definitely seen. So they presented with febrile seizures with a upper respiratory type of presentation, but on investigations we found that they were having influenza H3N2 or something of that sort. Encephalopathy, I can remember only offhand one patient who had a picture of encephalopathy, but otherwise not very many atypical presentations.
Okay. Of course, I remember a case of acute necrotizing encephalitis, which is also reported in the literature. And would you like to say anything more about the complications related to influenza? Respiratory complications already we have discussed, like otitis media, pneumonia, and co-infection with the other bacteria. And I'm sure in case if at all you have to give some antibiotic to these children, it's always paracetamol and never aspirin, because I'm sure at least during my residency days we used to see those patients of influenza being given aspirin and developing Rye syndrome, which is very very critical condition related to the liver. And of course some of our colleagues, they have seen myocarditis and pericarditis. And myositis is something which is also commonly seen, particularly with influenza B, where the gastrocnemius and the soleus muscles, they get inflamed and there is severe bilateral calf muscle pain. And that's why the child is not able to walk. Of course, I will be asking you a bit of, maybe quick questions just to, complete the discussion. So, Dr. Sainath, there is, a child who is 8 month old, and the elder sibling of this child is admitted for influenza A with LRTI. And this younger child, 8 month old, or day. So will you put this younger child on oseltamivir?
Yes, sir, because as we are already saying, ki there is elder sibling is diagnosed case of influenza who is in critical condition, we can say, or he was admitted. So definitely, as this is a contagious disease, and it is this patient is also in the same family, same house, definitely is more prone for this influenza virus. So definitely, I would start this patient early oseltamivir therapy.
Right, right. And moreover, this 8 month old child falls in
Yeah, and the
category
age is also very important. Yeah.
category B. So that's why he's in the high risk category.
Yeah.
And Dr. Sanjay, in case if the child is not accepting the oral medicines, are there any alternatives to this medicine?
Unfortunately, that is one problem. There is no IV preparation for oseltamivir, so we have to ensure that the child takes the medicine orally only. And as I said, preferably giving it on a full stomach helps in retaining the medicine as far as the small children are concerned.
Okay, and I have one question to you, whether one should give chemoprophylaxis to all the household contacts of the child?
So probably not to all household contacts, but definitely if they are having some predisposing conditions, for example, some chronic kidney disease or a chronic congestive failure or something of that sort, or elderly person in the family, say 70-year-old grandfather or someone of that sort, then definitely yes, a diabetic patient, one with a chronic liver disease. So yes, these people will definitely deserve a chemoprophylaxis.
Very good. And then Dr. Sainath, if in the current situation, if a child comes to you with high grade fever, a severe sore throat with cough and cold, and mother says there is a lot of illness, like the child is really unwell. Is it an indication for starting oseltamivir in this current situation, as per your
Yes,
opinion?
yes, yes, sir, yes, sir, yes, sir,
Okay.
definitely.
Yeah. Yeah. And then
Before
Dr. Sanjay, yeah, yes,
before
you
antibiotics,
want to
if
say?
the in current scenario, we would start them on oseltamivir, and if he does not improve, then we may think of antibiotic.
Okay. And Dr. Sanjay, what is your opinion about this oseltamivir, whether it works on para-influenza viruses?
No, it does not. It is very specific for influenza viruses. Para-influenza virus infections would require just symptomatic treatment, and usually they would resolve with that.
Right. And I'm sure our colleagues know that para-influenza is an infection which produces croup and stridor, and that is very typical of that para-influenza virus. Anyway, with all that, I must say that the onset is abrupt, the transmission is high, the progression is rapid, develops acute respiratory distress syndrome very fast, and even oseltamivir has to be given very fast. Okay, and with that, one must remember that not only the early treatment with oseltamivir, but also certain etiquettes related to cough, and also certain important facts related to the hand, which I always refer to as Hasta Pancha Sutri. Hasta is hand and pancha is five. Okay, so there are five sutras related to hand, One of them is, of course, hand washing. Second is avoiding the hand shaking. Third is using the handkerchief. Fourth is keeping the other person at a hand's distance, and also avoiding hand touching, because as I told you, the spread could occur through fomites also. And of course, one must not forget to take the flu vaccine every year. And that's why I also always say happy birthday to flu after saying happy birthday to you. And probably, that is the best gift which you can give to your, grandparents, particularly, on their birthdays. So with that, I thank, our listeners and our panelists for an excellent discussion. And I would always take leave of you by folding the hands, that by saying namaste, and not, of course, by shaking the hands, because we have already seen that namaste is better than a handshake. Thank you very much.
Thank you, sir.